Welcome to the Education Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsor, Limmer Education, we can make science more accessible and understandable. Hello, everyone, and welcome to the April 2024 Pre-Hospital Care Research Forum Education Research Journal Club. The PCRF promotes research literacy to advance the science of EMS educational research. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. Thank you to Limmer Education for sponsoring these podcasts so we can bring you the best of science in medical education. I'm Megan Corey, and I'm here with Katie O'Connor and Michael Caduce, Alex Tremblay, David Page, and Dr. Bill Toon. We got a full house for you today. So today we're going to discuss this article that was published in Pre-Hospital Emergency Care this year, and it's entitled Improving Pediatric Procedural Skills for EMS Clinicians, a longitudinal simulation-based curriculum with novel remote first-person view video-based outcome measurement. Say that 5 times fast. So this is a study that's used out of Southwestern Ohio. Thank you all for joining us today. We're going to begin. We're going to remind you that you can use the chat feature on your screen to type in questions and comments. We can bring in Q&A into the conversation as we go as well. So remember, if you miss any of these journal clubs, you can catch us on our very own YouTube channel. We have archives of past journal clubs, both the clinical and the educational, so you can catch those. And if you have to leave early today, this will be up there too. So catch us on our YouTube channel at youtube.com/@PCRF@UCLA. But before we begin, we want to make an announcement about the upcoming opportunity for submitting your research. So David Page, I don't know if you're in an area where you can unmute and tell us a little bit about this. Dave may not be. Yeah, are you there?
Can you hear me?
Yep, we can hear you.
Very, very exciting opportunity. Everybody should send in their research, calling all researchers, all abstracts, all projects. It'll be an exciting international scientific symposium this year in Las Vegas in conjunction with the MS World Expo. We hope to break some records, so help us break the record by submitting your incredible research. We've had a record number of workshops with PCRF this year, still some coming here, so check into our website, prehospitalcare.org, and participate if you can. You'll come out of it with an abstract, come in with an idea, come out with an abstract. But we're in enough proximity for NAMSP, so if you submit to us, you can also submit to NAMSP, and your abstracts will be published in Pre-Hospital Emergency Care. We have some $500 prizes for best research in education, best research in clinical abstracts, and up to $2,000 worth of travel stipend to present your research at an international conference. And when we collaborate with the Australians and the Europeans and our friends in Asia, you can be invited, and we are helping our researchers get their stuff disseminated all over the world. So June 30th, don't forget it. Be there, be square.
Awesome. Thank you. So June 30th, right around the corner. We're going to remind you again next month as well. Remember, it doesn't have to be fancy schmancy. It might be something you're working on in your own college or in your own EMS agency, maybe something that you're really interested in, a piece of research that you can grab a couple people, collect some information, and share it with the masses. So come on out and get those abstracts in. All right, so a little bit of background on this research. We had some great conversation, as we usually do, before we even come on to talk on this podcast. But one of the challenges we know, and we've talked about this here, in pre-hospital care is maintaining your knowledge and skills, and then keeping current and evidence-based medicine, and then your local and regional protocols. So adding to that low frequency and high acuity situations, or even just low frequency situations like pediatric patient encounters, and the ones that have the potential for harm or substandard care, add that to, the difficulty in maintaining skills. And yeah, then we've got some potential for, again, substandard care. So, and who has the resources, time, training, trained trainers. So that there's that piece, the educating the educators, and then a training program that's backed by evidence. That's a challenge too, that the personnel are going to even retain those skills, or even the people teaching retain their teaching skills. So all of these are challenges that we know we face. So this research group wanted to take on the procedural skills aspects of the high acuity, low frequency pediatric patient encounter, in particular cardiac arrest, by designing a study for licensed and certified pre-hospital personnel. So this is actually a continuing education study. These are clinicians, not pre-licensure personnel. And this is pre-hospital personnel in urban, suburban, and rural agencies. And then they wanted to test out the following objectives. So what they wanted to do was to describe and assess the effectiveness of a pediatric focused, what they call a simulation-based training program. And we'll get into some of the details. It turns out really to be a procedural skills program that's designed for EMS clinicians. And then they also wanted to provide a proof of concept for something that was novel. This was implementing a first-person view video, so kind of like body cam video, using like GoPros to capture the procedural training and the assessment of the procedural training. So that part of it, it was novel in this study. Okay, so essentially what they had was 3 fire-based agencies. Let's see. 3 fire-based agencies in southwestern Ohio, rural, suburban, and urban. These were identified as transporting agencies to the local pediatric emergency department, and this is where the authors were from. So that's how they identified them. They contacted the training officers to explain the curriculum and the research, and then they recruited full-time and part-time participants. There were 3 skills: intraosseous infusion, bag mask ventilation, and then using a bag valve mask, and then a supraglottic device. And I'm not sure which supraglottic device. I didn't quite catch that in the paper. I think I scanned it a few times. All of these had to be within the scope of the of practice of the practitioner, but they also didn't, tell people they couldn't participate in the training, which I thought was interesting. So the study participants, it had to be within their scope, but they actually included people, in their study or in the group, in the education. They didn't include them in the study results. So this is the agency characteristics that you can see, and this is how they, these are basically the characteristics of the agencies that they had, the 3 different. So you had the urban, the suburban, the rural, the square mileage, the size of the population, total calls, and then the percentage of pediatric patient calls. So you see, and I don't know how this compares. Actually, Michael or Dave or somebody, how does this compare nationally? 6.5%, 5.5%. I don't remember from the practice analysis.
I think it looks pretty reasonable. I look for anything less than 10%. So they 16, we'd have to look it up because most places track 18 or less. So 16 or less is whatever, but yeah, I'm sure it's about reasonable.
Yeah, pretty much the same. Okay, so
this is about right. What I was
it?
going to say in kind of support of Michael, like the organization that I have done data for many years, 13 is our cutoff for pediatrics. At 14 or older, they generally can fall into the adult guidelines. So I think picking 16 is odd, but yeah, this would be about right for us as well.
Good point. So where do you pick that age, and what does the practice analysis, the National Registry practice analysis use? Is that I can't think of that off the top of my head actually, but some use 14, some use 13. Occasionally you'll see 18, but that's a little bit older. You're getting into the kind of, what is it? What question are we looking at there? That's a really good point. So, but we see that the percentage is pretty much along the line of what we see nationally. number of paramedics and full or part-time, and EMTs on staff as well, just kind of the characteristics of these agencies. Let me see, the next one we got how they ran this. So first, before we talk about the enrollment, let's talk about the training a little bit. So they had a task trainer training and what they called a simulation-based training, and this was team training in a pediatric cardiac arrest simulation, which was a drowning scenario. They used a mobile simulation unit, which I thought was kind of cool. I don't know if you guys have any experience with mobile simulation units, but this team had mobile simulation units. They essentially what they wanted to do was look at 3 time points. They wanted a pre-intervention, an intervention, and a post-intervention time point. And the post-intervention time point, they wanted it out at about 3 to 6 months. It turned out that they got interrupted. We'll talk about that in a bit, but they got interrupted by COVID, like a lot of people did. And the post-intervention turned out to be out longer. So they used a mobile simulation unit. They had a total of 3 sessions at the initial, 3 at the intervention, and at the, 3 at the follow-up. So it was a total of 18 sessions that they had, because each site would have this. So you'd have 6 sessions per site. It was actually 3 and 3, 3 sessions, pre-intervention, 3 post. And they about 4 to 8 hours for the initial, 3 to 6 hours for the follow-up, around that. So this, if you start, kind of tabulating, those of you who are behind the finances, start tabulating, how much cost it would be for this type of training. But they also did it while they were on duty. So if the training happened, if the crew got a call, they left for the call. Then they came back and they continued right where they left off. So they didn't start over again just for purposes of the research. They didn't start over again. They'd go on the call and they'd come back and pick up. So it did give you kind of a practical aspect of doing a training rather than reassigning groups to training and having just the training session. And I'm really glad they did it that way. I don't know if that was by design or whether it was just the only way we were going to get it done. But I thought that was interesting. So I'd like to bring in, Michael, Katie. What did you guys think of the training? So we had the task trainer training of the IO and the supraglottic airway and bag mask ventilation. And then the use of this follow-up, of use of the skills checklist. All the while they're carrying these body cams or wearing these body cams during this. Let's look at the task trainer stuff first, because then they go into the team-based training.
I think it's really a unique way to do a study like this, where they where they had like the GoPro cameras on. We'll get into the results and we can talk a bit more about what they actually discovered and maybe the methodology there a little bit. But
Yeah.
I think evaluating task training is fine. I think the bigger educational thoughts in my mind would be, we need to evaluate the simulation. We need to induce the stress. Katie is the simulation expert, so I'll let her sound much more articulate than I will. But just having people do a task trainer, to me, doesn't mimic the environment where I want my providers to perform. I want them to perform under pressure in an environment where I can expect them to be out in the field. No one's calling 911 and saying, I need you to walk into this room, put this IO in, and leave.
Yeah, Michael, exactly. I think the problem here is this is a group of people who are doing continuing education, not initial education. And we're kind of doing initial education for people who already are past this point in their learning. So if we're thinking about like scaffolding learning and like progression of learning, we really should be at summative kind of simulations for this group. They shouldn't be at our isolated, discrete skills. Now, I think that it's fine if you had identified in your department, in your agency, in your geographical region, like they're doing here, that there was a problem with the procedural skill, to start here and try to solve that problem. But as we're going to see from the data, they don't have a problem with procedural skill. So I think we could have jumped right into a more training that would better translate to practice. And if we're just thinking about this in general in EMS education, this is kind of like our safe zone, where we're really used to just pulling out the IO trainer, pulling out the airway trainer, training a discrete skill on a table. And we're not doing as good of a job of simulating training in a way that transfers to practice. And we generally don't have data that shows us how to do that anyway, because we don't have research on that. So this is, they talk about it in the paper, but we really need to start moving towards something that will translate to practice.
I thought it was interesting too. They mentioned in their methods about taking out, they sort of somewhat included the new hires. So they must have hired some people during this sample size. They included some of them in their survey results, but didn't include them in some other things. And I would have really liked to have seen the results. If these were new hires because they just came out of initial training, I would have been interested to see how they performed. There's not a lot out there on how does your initial education pediatric training, right? Like how long do you continue to maintain that knowledge? The AAA, the HA tracks things like that. How long do you stay proficient at
Yeah.
CPR without actually doing it?
Yeah.
So I would have liked to have seen that, because they did say they had some new hires. Now I don't, maybe they came from other agencies and they had previous, they were not, brand new out of school, but I would have liked to have seen that breakdown, just to say, hey, is there some factor in there that affects you because you were just in initial education? But
Yeah, I was thinking that too. I was thinking maybe they came from neighboring agencies. They could have had a lot of experience too. So I guess just the new hire alone wouldn't tell you a whole lot. The other thing was including all of the other people. I thought was actually a good idea, because one of the things we do know that happens is people train each other. So you're out on the ambulance and you're with your partner and you say, hey, I went through this cool training and this is what happened. I learned this stroke scale or that, whatever. And you get this kind of training in the ether that happens that's hard to measure, that is outside of the research. So I like that they inserted the practical pieces in here and they didn't make it so sterile an environment that it was hard to translate, that it would be hard to translate into kind of reality. I don't think I did a great job in describing this methodology. So because they do have a great methods section, and but it was a little bit confusing because they mention that the groups come in, they do a pre-intervention assessment. The 3 groups are created and then they go through these task trainer, after the pre-intervention, they get divided up and go through and rotate through these individual tasks. And when they do, they get a short didactic, a hands-on practice, and then they do a post-intervention assessment. Then they talked about this team-based scenario. And the team-based scenario they describe as a drowning cardiac arrest that was run for like 15 or 20 minutes, but then they follow up and say, oh, but we didn't collect data from that. We didn't collect any of the procedural data from that. But then they don't mention what they did do with it. But there is some sort of line somewhere in the paper too that says, by the way, this is part of a longitudinal evaluation. So I'm assuming we get to stay tuned and come back to that. I didn't quite catch where that scenario came in, because, and I was wondering, well, maybe if they did the evaluation of the procedural skills within that scenario, that would have been the value, right, Katie? That's what I was thinking.
Yeah. I think that that would have been, when I was reading this paper, I was like, oh my gosh, that's so cool. They did this task trainer and then got the sim bit, and then I got to the end and I was like, no.
Yeah, yeah, it was
is there
just
part
on
2 coming?
I do have a feeling, yeah, I have a feeling this is part 1. It would have been nice if they could have called it part 1.
Yeah.
Then we would have known, okay, to be continued. But and again, in that session, in the section on the methodology, they had this great description of the video reviewer training. Did you see that? The video that stood out to me.
Yeah, I think they took a really some of the things that from this paper I think are even more exciting than the actual did we do anything with pediatric care, is all of the things they're talking about from the education perspective, right? They took someone who has no knowledge, has no experience, and trained them on how to review the skills to see if they're doing the skills appropriately, and they showed that they were just as good as a pediatric fellow, right?
Yes.
So I think that tells us, hey, we can do a lot with interrelator reliability training to get all of our evaluators up to the same point. And that's something with the sunsetting of the psychomotor exam, where I think a lot of places just relied on, oh, we'll just have this national registry test and that'll tell us our skills are good. We can start doing some of this stuff, right? And the other thing that they said is they could evaluate the video review anytime they wanted, right? This idea that you could have the providers do the skills when they're available and have the person review them when they're available. It doesn't have to be synchronous in this age where nobody has enough time, nobody has enough money. This is a solution that they really nicely showed here.
That was the gold nugget I took from this paper, was some of the methodological stuff in their training, and actually in the video reviewer training. There's a whole section on how they guaranteed or how they built inter-rater reliability, and they actually worked on it. These video reviewers continuously reviewed videos and then worked on and then discussed with each other why a certain score was a certain way, and until they were able to review these videos separately and come to the same conclusion. And then they decided, after saturation of that they were all ready to do that there was good inter-rater reliability, and they were ready to do review. That was tremendous. I mean, that was I thought that was by itself one of the best things I'd read in a paper in terms of the methodology, good research methodology. So, all right. So then the follow-up assessment, we said it was supposed to be 3 to 6 months, but COVID interfered. So it was about 9 to 11 months. They tell you that later in the paper. They do the same assessments again with some individual. Oh, the other thing I liked is that in there, they said, okay, after you come back and you're going to do your follow-up assessment, we're also going to provide you with some individual training after it was all done. So they got some feedback, and it was individualized. So if Michael came to the IO skill station, and after this is the follow-up session, and after they were reviewed, he actually got feedback. So it wasn't just, thank you very much for your participation, now go to your next call. I thought that was pretty cool. So it was very involved and overlapping. It wasn't just, this is our, again, sterile research field versus education. It kind of overlapped. And then they did an electronic survey afterwards about their personal experiences with pediatrics in the meantime over the last 9 months, and then how they feel their educational needs are in terms of pediatrics, and then they compared those. So you can see in this table, this is a typical enrollment flow chart that you guys have seen before in research. You've got your total enrolled, and then you've got your ineligibles or other exclusions, not too many there, 127 eligible, 109 participating at the initial. You had some people that joined at the follow-up who didn't go through all of the training and everything, but they still kept them on the survey. They still did the survey, and they still had some videos there. 537 videos, and then you can see about 200 of the pre and post intervention, and then the follow-up, the later videos. And you can see each one of the groups: airway, which has bag valve mask and supraglottic, and then the IO groups, who started where, but they all did all the skills. So that was the essential, the enrollment flow chart. So their primary outcomes were performance of procedural skills across the 3 time points: the pre-intervention, the immediate post-intervention, and then the follow-up. And so that was their primary outcomes. The secondary is going to be comparison of agency and survey responses. Okay, so what they said from this table, let's dig into this, and this is where I want to open it up to our panel here. What the authors said was they saw improvement across all time points, but that they started with a high degree of proficiency. Of course, you know that right away, right? When they come in and you do your initial, are you hoping, well, it would be nice if they were less.
Megan, I think we're still looking at the demographics.
Yeah, actually, this is the demographics. Sorry. So this is the table of the demographics. So right here, we're seeing just the overall. I don't think there's anything earth-shattering about the demographics. We kept, quite a few. I don't know, Michael, if you have any comments about the demographic
The
table.
only thing I noted was they have a lot of providers with a lot of experience. So I think that's worth noting in the study. If you bring in a bunch of people who have done this for a lot of time, now granted, they don't see a lot of pediatric patients, but the things that we do care about, like stress and stuff like that, these people have been able to sort of develop stress, like their stress response is not to immediately port the accelerator to the floor when that cardiac arrest call comes out, right? So in my mind, that does, it probably only helps the study in terms of get the results where they want them to be. But it's worth noting that they had very few people in the study with less than 10 years of experience.
Yeah. We also don't know what their previous training program was. So what was, what in each of those agencies, what's their cycle of training?
Yeah.
And even their culture around it. That's another question. Okay, here we have the procedural outcome model results, and this is the IO versus bag mask ventilation versus supraglottic airway at all of the intervention time points and their p-values. All right, what did you guys think of this? We have pre-intervention scores, and these scores, by the way, they another thing I really liked about this article is that they included every single score sheet in the appendices. There's like, I don't know, 8 appendices in theirs that they included everything for us. So no secrets.
I just want to say, like, I don't know if we're measuring what we think we're measuring. Like, this is one of those kinds of like, did we set up the test to measure specifically what we want? Or are we measuring something else? And I think that the research guys here could be more eloquent on this and like what the p-values mean in the start and change. But I just am not sure we're actually measuring anything here.
I took this to mean like, does it pass my sniff test? And yes, okay, so I have a group of people. I had them do something, which they should have been somewhat competent in. I gave them some additional training and they did better. My mind's not blown when they did better. That your training was effective, at least in that sense. So the pre to post, I didn't spend a ton of time worrying about. It should improve, right? That sort of is, unless your training is just really bad, or you just have really, really great providers starting off with it, which is not, they did not describe that in their introduction. So I don't think that's the case. So I was paying a little bit closer attention to the follow-up. So 9 to 11 months later, did they maintain this skill set? That's really what I care about. And you don't see, we'll see this throughout a few other places. That's where I didn't see a huge change in p-values across the board. They did see some increases, but in percentages, but the statistical significance wasn't there. I think the one thing that I'll say, and then turn it over to Alex, who I see is on, is that we have to be careful anytime we have high success. And we're comparing high success to high success. So we're comparing a 95% yes, they did it right to a 97% yes, they did it right with a fairly small sample size. So this is they did the methods to figure out we have enough people for this to mean something, and they did do that research. That's why they had 143 people initially, so that if they lost a few, they could still be above their number needed to make this valuable. But you had a lot of high numbers in the beginning and a slow sample size, so p-values p-values may suggest significance in statistics, but not in clinical practice. So just that would be my caution.
Yeah, I think so. This is good math, right? Big fan of math, as you guys know. And so a couple of things that I want to point out, and I think Megan's going to pull up a box plot in a minute, and we'll talk about box plots. But here's what I want you to see. So the pre versus post intervention, highly statistically valid. Pre versus follow up, mostly statistically valid, right? Post versus follow up, again, also relatively valid. Okay, so the randomization cannot be accounted for as normal variance, right? This p-value tells you. But I want you to look at the confidence intervals to the right of the mean scores in these boxes. So from pre-intervention to post-intervention, there's a valid change in confidence intervals, right? There's no explanation overlapping. In the follow-up, essentially everybody forgot everything, right? And so, Megan, is the next slide the box plot?
Yeah.
Okay, box plots are great. If you haven't seen one in a while, this is a good example. But here's what it's telling you: the bottom line of the whisker is your lowest quartile, the top line is your highest quartile, and then the box in the middle is your interquartile range, right? So the middle of the data. The circle, in this case, the circle is the mean, and then the line is the median. You'll notice that the mean and median are relatively similar. Again, because this is a smaller study, it's very likely that your mean and median are going to be close, and if they're not, you likely have some significant outlier that's giving you trouble. So again, this is a really great visual representation of data, but this is where the rub is that the column A and column C in each of these charts shows that there is no retention or limited retention. Okay, and so the mean scores are a little bit higher, the whiskers are a little bit shorter, right? So the variance is less. There's a little bit less explicable variance, but ultimately we kind of slipped back into old habits. Now, I think that's important to understand, and that oftentimes when we do our work in EMS, we pave cow paths, right? We do what we can in a de facto sense, and slowly but surely that becomes our practice. And going into a sterile environment and trying a skill and getting better at what they ask of the sterile environment skill is important. But then as soon as you're gone, you're right back to forgetting to wear gloves, right? So again, I think this is really good data. I think it's well presented. You don't see a lot of box and whisker plots anymore, and so I'm appreciative of that. But again, I think that what this really shows us is how poor the retention was overall.
I'm going to challenge you, Alex, and I want to say, is it potentially showing us that maybe the sterile environment skill is not the one we should be doing? Like that could also be the case here, right? So maybe when you go into the field and you're actually treating real patients, you do things differently because it works and it improves patient condition. And so that's
Yeah.
why we're not doing the skill, like skill sheet wise. I'm just thinking of what we were talking about earlier. The skill sheet here was you must like attach to oxygen before you give a ventilation. And then
Right.
missing this. And is it because in the real world we bag someone and then attach to oxygen because we just need them to breathe? So I don't know. We don't know because it's just data, right? But I would say that I think we sometimes jump to the conclusion that we're losing skills in the field when maybe we need to change the way that we're evaluating skills because they don't match how we need to do this for real human beings.
Yeah. So I think that's what I meant by paving cow paths, right? Like eventually we do what works best for us and what is most applicable for the work that we do, right? If you work with the same person all the time, things go really well. When you work with different partners or in a different environment, things can change, right? So that's not to say that people did worse, right? And I probably should have explained that a little bit better. People went back to what works for them is maybe a better way to say it. And the hypothesis here that they're testing is, do they go back to doing the sterile environment? And so in nature of what they're saying is no, but in nature of what actually works in healthcare, what works in the back of an ambulance, yes.
Maybe, yeah.
Wow, we're going to take a look at each one of those skills in just a second, but I'm going to keep you on, Alex, for just a second because I need remedial box plot here.
Okay.
Just so we know, just so I'm clear. These little pluses, those are outliers? What are
It's
these?
not in their data definitions at the bottom, which is a little frustrating.
Yes.
But it would be reasonable to assume that those are outliers. And that's
Those are
why
outliers.
I think if you look at A versus B here, the width of B, the whisker for the lowest quartile, there's no outliers because the width is so wide, versus in A, in the pre-intervention, they have this really narrow range of data and 3 people that are just way off, right?
So the confidence interval between the two hatch marks on the on the line and the blocks are the interquartile range. And then we see the circles and the lines as being the median and a mean and median.
That's correct.
So, so they're way outlined if they're outside the confidence interval, right? That's what we're talking about.
Yes.
Again, doing remedial box plot. Sorry to bore those out there who already know this, but I really like to understand what I'm looking at, especially if people are going to take the time to say, in addition to our table, we're going to make it pretty for you. Because this is all on a table. So now we're going to put it in a, whoops, sorry, that was me just kind of going ahead. Subliminal.
Okay. I think it's color blindness issues like myself. This doesn't tell us anything that the table doesn't tell us, but it's important to really look at. Like those outliers are helpful to understand. But yeah, I don't know that it really tells us anything that the previous slide didn't.
I think too, we have to caution ourselves because their accesses aren't the same. So the total score, I always like to start my box plot, any table at 0, because it looks like in table B that you have like this 0 to 12, like you have a huge outer quartile range, but you don't. It's because the table starts at 6, but table A starts at like 3-ish, and table or C starts at 2.5 and goes to 15. So I think if you're looking at this and it's a little bit confusing, I looked at just the olive green because that's the overall, and they cite in their methods that it doesn't, the rest of it doesn't matter. It's not statistically significant from locale, so suburban, urban, rural, whatever. And then again, you sort of need to adjust your frame of reference for each table. So it would have been nice if they would have started them all at 0. I think it could have given us a little bit more insights. It would have made the quartile ranges smaller, but it might have given us a little bit of more ability to compare.
Or put a broken line in the bottom left-hand corner so that you know that it's not at 0. Yeah.
Yeah, this is a great discussion because I think data visualizations are important. They're helpful. We like to see things that we can, where you can pick out patterns or whatever in a visualization. And this is one of them. And but it's also important to know that a data visualization can also be deceiving. And what Michael and Alex just brought up is really important. To be able to understand, we've got to look at our axes all the time. And just one more question, Alex, is it fair to say too that the variance or the variability between scores as represented by by the confidence or by these whiskers, is as important as the changes, when you look from pre to post to follow up, looking at how much the scores vary is as important as the scores themselves.
Yeah, absolutely. And I think, again, if you look at the post, and good call out by Michael, that brownish greenish, the far right box is the one that is significant. You'll notice that in the post intervention phase, there's far fewer outliers. They're much closer, but those whiskers are so tight, right? The interquartile range is so narrow. That's just as important. You'll see too in the AIO post, there's no upper whisker, right? Because the top score is also the end, the 75th to 100th percentile. So yeah.
Okay, that's another good point. Great. So now let's look at each one of these. And this is where Katie, I think you were talking about. I can't remember if it was the IO or the airway ones we were talking about, but there's 3 of these tables that breaks down what they were actually scoring. So it was yes, no, did they do it or not? So their score sheet, their checklist, which is in the appendix, basically is mimicked here. You can see that they have the 1 through 12 steps, and it's yes, no, did they perform? I'm still kind of interested in why we didn't see this in the actual scenario. And again, I'm assuming we're going to see that eventually, that they're going to come back and say, okay, by the way, in that drowning scenario, we scored them too.
Yeah. Well, so Caduce was mentioning too, some of these like dichotomous steps, yes or no, like they just don't pass like a face validity test when you're like, I think on this one, IO, we have the like number 8 disconnects the drill from the needle, and they have people that have no, and we're like, well, how do you like keep going? Like, how do you get yeses further? Like, did the skill just stop there for some reason? Same thing like with like connecting the needle and the drill. Like, of course, everybody got 100% on that. Like, I don't know how you could do an IO without having the like, because they specifically did easy IO. So, like, do you think someone would grab it and like Jamshidi style it? Maybe,
Yeah.
but I'm not 100% sure that like that score there is like the same as the disinfects the access site. Like for me, like aseptic technique, we're like kind of, I would grade this as like way more important than did you connect the needle and the drill? Because I feel like that's just yeah, of course you did that.
Yeah.
Like it's like writing your name on the top of the paper. You don't necessarily get a point for that class.
Yeah. Well,
Um,
we talked about that with testing too. When you have a test and you have a higher level test item, do you give them more points if they get it right? But then, of course, if they get it wrong, they get more points off. So that's always been the discussion, Mike.
I think I'm spot on what Katie was saying. I think we'll see that even more in BVM, I think, too, where you have a life-saving intervention and you sort of have to do some things where some things like maybe less important. The one column here where I actually thought there was value is the pre to follow-up, right? You tested them, you did an intervention, and then 9 to 11 months later, did they have any impact? And so this goes back to what Alex said. Did the training make a difference, or did they go back to their in essence bad habits? Which I think Katie made a good point of, like, it could be good habits that they went back to too. We really didn't evaluate that per se, because we didn't evaluate it in a real life environment. But nonetheless, you didn't see a huge amount of statistical significance here from follow up. So you did from pre to post, which again meant your education in the moment did some good. But again, your follow up to later didn't make a huge change in statistical significance. This post to follow up, I think it's interesting to look at that. I don't know I guess it means that you were taught to do it the right way. You did do it the right way, and then you slipped back into your bad habits, or different habits.
Not different, yeah, different, not necessarily bad. We don't know if they're bad or good.
Yeah, I think that's and I think that's a really important clarification here because we don't know that. So there was some statistical significance in the post to follow up. The other one caveat I'll have is if you're looking at this quickly and you look at the ends from pre to post and follow up, just remember their ends got smaller, but their percentages got bigger. And that's because they had less people in their follow up. So if you're like, how did it go from 95 to 64 of wearing gloves? Well, their percentage actually increased a little bit. So it's just recognize your end size changes there. So if anybody's looking at quick, but that would be my takeaway from this one. There's not a ton of statistical significance here.
And then here is the bag mask ventilation, and it'll be the supraglottic airway. The other thing I have to say about these check sheets, and it kind of gets to what you're saying, Katie, is, you know, the checklist for somebody who's just learning a procedural skill is very different from somebody who's already got the procedural skill down. Like connecting things to this, it's more like IKEA, right? Put this here and connect it because you've never seen this before, and then practice it again. But when you're out there working it, it's not that device. And that previous checklist is very much device oriented. And they did say that it was from EasyIO. It wasn't based on what are the best practices when you're obtaining IO access. It's kind of like a skills checklist for splinting. We know the principles of splinting. You got to check CSM before and after you splint. You know, you have certain pearls. Those are the things you look for, not open the Velcro straps. And that's IKEA. You know, that's how to put a table together.
And I think like on this one too, it's like, what are we actually testing here? Is this something that will translate to better patient care?
Yeah.
And like we look at number 8, they're like demonstrates correct mask technique, either one-handed or two-handed. But I think that like if you look at the push now, it's you should always be doing a two-handed mask technique, right? So like why are you getting credit for one-handed? But it's because we designed this research study that they went in by themselves, right? So I think like some of the things, if we want to really be as educators, as researchers, I mean, they're really doing an education intervention here that they happen to research, right? But they were going out and training providers. And I think it's really dangerous if we go out and we train providers to do a one-handed technique. We're kind of accidentally emphasizing that you could do a one-handed technique. When, sure, I get it, we don't always have all the people around and we should be doing two-handed techniques, but we're literally scoring it the same. And, you know, if we're trying to say we should be doing two-handed techniques all the time, then we should be getting some kind of point, I think, if you're in your head thinking, where's my other person? I should get another person here. So yeah.
There's a great conversation going on in the chat earlier too about the about, you know, when to use certain techniques. Yeah, Claude makes a good point. You don't necessarily need to use the two-person technique for children. So
yeah, but this is the kind of conversation like you don't need to, but it's optimal. Two people on the airway is optimal. It's like, so yeah, sure. Can I get chest rise on an adult with one hand? I can. It's not optimal. It's not doing the best interest of the patient. I was having a conversation with my EMT student or my medic student about where we put EKG leads on. And we do this thing where we like give ourselves shortcuts in EMS and we just say, oh, well, we can, but should we, is I think the question we should be asking.
Yeah. Yes, you know, the airway compendium has that whole section on ventilation. That's a good evidence-based review of the appropriate, makes recommendations, two-person bag valve comes out of it. I don't remember the pediatric one, but there's a separate pediatric paper in the airway compendium. I would strongly recommend going back to that too. That was in January of, I can't remember, 2022, 20. That is
we can put the link in the chat.
Right, and we don't even have Catno on here, right?
And they did all the homework for us, right? Those groups did all the homework for us, and the airway compendium, you can just pull them and say, what are the best practices? These groups did the review of different practices and came up with recommendations for us. So yeah, that's great. The other thing, I was looking at something in here too. Not putting pressure on the eyeballs is really important in infants. And it's the reason why it comes up is it's really, you know, it's because it's a vagal maneuver, right? So putting, when you're doing especially a single person bag mask ventilation with an infant, it's easy to rest your palm on the eyeballs of the infant. And so, or the edge of the mask. And that's a pearl that's in PALS. And I would think that would be really important. So those are, you know, things that benefit that like you're saying, what do we have as evidence that would protect the patient? That's not, you know, putting together the device and doing the procedure.
I'd be interested in other thoughts on it, but this study also made me think that it's maybe a better, it continues to confirm to me that going away from the ALS skill test for NREMT is probably an okay thing, since they use, I
Yes.
mean, their appendix says these are NREMT, they used NREMT skill sheets for these. And I was like, so it's probably not, it's testing exactly what you've designed it to test, which
Yes.
may or may not be actual best practice. So to me, this is one more study saying, yeah, training them to the NRMT skill sheet and then expecting that they maintain those habits didn't necessarily play out in your study. So maybe that's another reason that the ALS redesign is a good thing.
Mm-hmm.
And it's, again, we talked about this, but translate to practice. I think these things don't take into account any of the decisions that have to be made in a real world environment where you only have 3 people on your team. So which thing is happening first? If we're doing an EZ-IO at the same time that we're doing a bag valve mask, is the same time we're checking a supraglottic airway with 3 people, like how does that change the dynamic of what should and shouldn't be happening? That that can't be captured in a discrete linear skill sheet.
I like on the supraglottic. So this is, again, the one column that I spent a lot of time looking at was the pre to follow up. So the sort of all the way to the right, but to the one to the left. And the only one that was statistically significant here was checks and prepares appropriate supraglottic airway device. And I really wanted to know in my head, one, what preparation do you need for supraglottic? Maybe putting some lubricant on it, I guess. But that's the, like, literally
Oh, that's
the
a
next
different
step.
number.
Yeah,
Yeah,
that's a
different
different
number.
step.
Yeah.
So I thought to myself, well, maybe it's picking the right size. I'm not sure, but I was like, the last time I put a supraglottic in, I don't remember doing any special steps to prepare it. It was grab it, lubricate it, and put it in the patient. So that was the only one that's statistically significant. And again, part of that is likely because at the beginning, probably no one knew what that meant, right? That's why only 54% of people did it. And then they trained you on what that step actually meant. And then in the post follow-up, of course, everybody did it because they probably verbalized, I'm assessing for the right, I'm preparing my device, right? Just, it's like the blade is white, tight, and bright on your laryngoscope or whatever, which you don't need for the supraglottic. So, and then again, people at the end did not do it at the follow-up point. So more sort of emphasis on the, does it really matter? Well, if they're not doing it in the field, then they didn't remember to do it in this test. So I don't know, again, limited clinical significance to me coming out of the findings, and even less when we look at the post to follow up. So did they maintain those skills? There's really not much there. Maybe again, checks and prepares appropriate device. But again, I'm not sure what that is.
We got some good, posts in here in the chat about pediatric BVM and overventilation, the issue of overventilation. And I've never heard of the EOLife.
I think that's the device that he actually sells.
Oh, okay.
Yeah.
It's there's, using certain things. Yeah, overventilation is definitely can be problematic. So that's something that we're always kind of mindful of. Any more comments about the supraglottic device here? Okay, so now again, I didn't see which supraglottic device they were using, whether it was the iGel or other LMA or others. Okay, so here is Appendix G, which is not the Appendix G that makes most paramedic program directors out there shudder. Appendix G is their post-intervention survey results. So they had the survey results after they had the post-intervention scenarios or skills and scenarios. They immediately kind of gave a post-intervention survey, and they asked these questions basically on their personal experience with pediatric patients. How long has it been since you personally cared for a critically ill or injured patient, and how long has it been since you participated in training, and then how frequently would you ideally like to receive pediatric focused training? So I'm curious what you guys got out of this. We had an overall response rate of 97, and twice as many in the urban setting that were in suburban and rural. We didn't see really any difference among the 3 different groups in terms of the response, except for maybe close in the how long has it been since you participated in training. But we saw, and they kind of broke it down into these very specific, groups, these months, several months at a time. The thing I thought was interesting, and they kind of came to the conclusion that they you know, they wanted training in generally, they wanted training about every 6 months would be good. That would be the preferred time to frequently or to receive pediatric focused training. They didn't talk about like, was this training itself, adequate and the problem is they ran this scenario too. So we don't know, they may have felt that the scenario itself was really good and but it was never really applied in the research in this paper, at least. But then the other thing is they cared for critically ill or injured pediatric patients. And we were talking before we came on, overall, we saw that within, let's see, this is within the last 11 months, if they were out at the 9 to 11 months mark for follow-up, you still had a 33 plus 15 people. You still had 48 that had a critically ill or injured pediatric patient, not just a pediatric patient, but a critically ill or injured pediatric patient. But we didn't ask about, their training. Did you start an IO? Did you use supraglottic airway? Did you use a BVM? Did you use any of the techniques? We didn't ask anything specific of those people. What would you think, Mike?
It's an interesting survey question. I think a different question that I might have asked would have been how long since you've performed an ALS intervention on a pediatric patient, just because critically ill is up to discretion of the person. So maybe a post-ictal patient that's a the febrile seizure patient is critical to you. But to me, I'm like, well, we're just going to talk them through it and monitor them so they're not really that sick. So I think there's a lot of openness to interpretation. I think we can all agree that we don't see a ton of pediatric patients and we see even fewer critically ill patients. That was well defined in their method or in their introduction. So
I was thinking it's interesting when we ask people like, ideally, how often would you like to receive training? I asked a similar question here, like ideally, how long would you like, what do you want to change about the class? And everyone's always like, I want more hands-on training time. I want longer breaks, but I don't want to spend any more time in class. And it's like, well, that's not how time works. So, when you ask a survey question like this, like ideally, would you like more pediatric training? Sure. But how many hours in the day are there? So I would love to see start asking questions like, would you give up something to do more pediatric training?
Yeah.
Would you, or can we change something out? Like, what do you feel like we're doing too much of that we could replace with pediatric training?
Yeah, the other thing to remember is these were recruits. So who are you going to recruit? The ones who will do it?
Who wants to do more pediatric training, right?
Mhm.
But they might be able to tell us like, hey, we're doing way too much. Like if they're like, I'm just going to use this as an example, RQI. Like we're doing way too much RQI. Like we would love to do a simulation where we're doing the full code with these integrated skills, not just compressions. That could be an interesting answer.
Yeah. Yeah. Alex, did you have something?
Yeah, I was just going to say that these, I would say, are not necessarily the most valid ways to ask these survey questions. So if you plan on doing post-training surveys, catch in with your local survey methodologist as well, right? So I think like question 1, question 2 is great. Question 3, like ideally, I would love to do this training once a month, provided that I have nothing else going on in my organization pays for it, right? Like I think you just have to be cognizant of the way you ask people these questions, right?
Yeah, that's a really good point too. So methodologically speaking, if you're thinking about survey training, don't just sit alone in a room and dream up questions. You want to have some type of guidance on how to develop a valid survey question, and then think about who the people are responding and how they might respond based upon how you frame your questions too. So the other thing I thought about this, so again, you had these people that had some kind of critically ill or injured patient, but we don't know whether they use those skills. The frequency of ideally receiving pediatric focused training, the way that they did this, they had the mobile unit. Well, I would have liked to have known, about that, about the ability to do this kind of thing. And I think we've heard from a few people saying somebody said they were going to be getting, I think Greg in the chat was saying that they were going to be getting a mobile unit next week, which is great. So having a mobile simulation unit that can go place to place is just a great idea.
Not only that, Megan, but they have people who are trained to provide the education and they specifically have the same people provide the same education for consistency. And I know Bill can comment here about like, we should pay people for their jobs that they're doing and we should make it valuable for their time. But I think that's really key here, right? We didn't just randomly bring someone in off light duty and have them like show them how to do an IO, and then the next week it's whoever else has a sprained ankle, they get to show you how to do a supraglottic. So that's really important.
Great. Okay, so any final comments about this study? We're a little bit early, but anything that you'd like to bring up related to this study that you'd like to see in the future? They said that they'll be continuing. This is a longitudinal evaluation. I'm assuming this is a first step in a longitudinal evaluation.
Yeah, I would have loved to see more. I think the data here suggests exactly what, like, I mean, it's always nice to prove it, but I would have just liked to have seen more in their analysis of like, this is what because you can describe your next methodology in this. You could have said, this is what we're going to do with it, or this is the tool that we're going to use to evaluate the drowning incident. So I think that's truly where the meat and potatoes of this study came from. I think it's great to like go back. If I was a person who had a mobile sim unit, which we had when I was at the University of Iowa, this would be a great thing to do, to study, to say like, look, this is why we need this unit. And you've got people that this is their full-time job. This is valuable. I want to see the translational science. I want to see it transition into improved patient care. I want to see it. I mean, if nothing else, then they at least kept doing it the right way. We don't know that here. We also don't know if this improved patient care or not. And if I'm the person helping secure more funding for this grant for your mobile sim unit, then that's what I want to see. So yeah, that's my takeaway. I think the supplements are great. If you're looking at doing something similar, I think you could adjust the methods here to really articulate that. So there's nothing wrong with this study. I think it's a good study. They got it published, and that's the monumental task.
Yes.
But I think you could easily upgrade this, if you will, to something that tells you more.
I just have a feeling it's a to be continued kind of study too.
Yeah, I agree.
Fingers crossed part 2. Can't wait for it to come out. I just think that like a real great takeaway for me from this was, look, we can do this. It's not that hard, and we can do it as a region, right? Like these kinds of things, because you don't use a pediatric trainer that often. You don't need every single department to buy one, right? Like, let's do this regionally. Let's share resources. Let's get our hospital group involved. They're the experts in some of these techniques and things, and they see way more pediatrics than we do. So it just, to me, was, although I have some issues with the skill sheets and some of the things they evaluated, overall huge takeaways. Like, you can do this. You can do it with video. There's like really, really effective ways to provide training, and they did it. So.
And video review is another methodology too. It's one you have to think very carefully about. If you use video in your simulation lab and you videotape either, this was procedural skills, which can be challenging. You got to, make sure your angles are right, that you have zoomed in enough that, it's hard to, it's harder than looking at an overall, maybe a simulation and performance in a simulation, but video review is very powerful. Just make sure, if you're thinking about it, that you have plotted out like your video reviewers. I think they did a great job there. They really were careful about their video reviewers, their training of the video reviewers, the inter-rater reliability, what they were looking for. We just didn't get the data on that yet.
But they also did this on shift. I don't know if we mentioned it, but it's again, you can do this on shift. You can get interrupted and you can still learn. Like, don't just give up because you're at work. Like, we have time that we can do this. We can learn.
Yes. Yeah, exactly. And that was the beauty of having the urban, the suburban, and the rural. So if anything, in all of these settings, they showed that you can do this in a busy system. You can actually pull people. They can actually go out on a call in the middle of it, come back and pick it right back up. And it's a valuable training experience. So, or it's worthwhile, especially in the populations where we know it's going to be high risk and very important to keep those skills. So that was great. So we'll be watching these authors and seeing a little bit more from them, hopefully, on their simulation training. And we'll be talking much more about simulation training in our future too. But first, we want to thank you for joining us today. And then remember, we are going to be here next month, but we're a week later than usual. So watch your calendar. We're not the 24th as we would usually be. And that's because we're going to come to you at the same time and day, Friday, 10 a.m. Pacific, noon Central. I think I got that right. And that's May 31st. And that's because we're going to be live from a Credit Con. So Credit Con this year is in Oklahoma City. We're going to be with primary author Michael Caduce and Michael Miller, who's from the COA EMSP. Ash Panchal will be around. We'll see if we can grab him to join us. And we're going to be talking about the article that actually has been reviewed. I think EMS Educator just did a review of this, so we're going to listen to that and see if we can fill in some other gaps. But it's perfect for a Credit Con since there'll be paramedic program directors, and with all the AEMT discussion as well going on at the with an SMSO SMC where AEMT coming out. Lots of very, very relevant information here. An article called Medical Directors, Facilities and Finances, Resource Deficiencies in Accredited Paramedic Programs. Very relevant to all of you out there, I'm sure. It's a pre-hospital emergency care. Is it open access article? So you can pull that. It is this year, and you can take a listen to us. If you're not at a Credit Con, you can listen to us live from a Credit Con. If you would like to join the Journal Club before then, the Clinical Journal Club, remember, with Dr. Remley Crow and Dr. Tony Fernandez. That will be on Monday, May 13th. And to join us live each month, you can come and register at prehospitalcare.org. Our archives are actually found on our YouTube channel. So don't forget our YouTube channel at youtube.com/PCRF at UCLA. And we will see you next time. Thank you. We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at www.pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website at www.prehospitalcare.org. A special thank you to our sponsor, Limmer Education, providing education tools for success at every stage of your EMS journey.